Okay. Good evening, everybody. Welcome again to our Wednesday evening webinar session. This is a combined session between FRCS and OR UK. My name is Shwan Hanari, one of the mentors. Today we have Nikki Evans, Joe Gowdy, and David Hughes with us supporting today's session. Today, we're very lucky to have Mr. Toby Barring. He's going to give us a talk on shoulder arthroplasty. I am really looking forward to this talk. He's an expert in this area, and I know that his talks are often very appropriate for the exam, which we're looking forward to. We'll start with introduction today, shoulder, and then we'll have a talk for shoulder arthroplasty, and then some questions. We'll have some case discussions and tips for the FRCS, but we'll close early this time. Before I continue, I just want to introduce Mr. Barring. He's qualified in Newcastle Medical School in 2000. He did his BST at Guy's Thomas and then undertook his postgraduate doctorate with Prof. Rogers in Emory at Imperial College in London. In 2006, he looked at surgery in the rotator cuff. His postgraduate training was in the Royal National Orthopaedic Hospital in North London, and he spent his fellowship in Nice in France with shoulder specialist Prof. Pascal Boileau. He's been appointed as a trauma and orthopedic consultant at Humberton University Hospital 2015, and he's the clinical director and practices shoulder and elbow surgery there. His specialist interests are shoulder arthroscopy and joint replacement and shoulder and elbow trauma. I am very sure we're going to get an excellent talk from him. I'm really looking forward to it. And without further complications, please go ahead.
Thank you, Shwan, and Hannah, and the rest of the faculty for asking me. Can you hear me?
Yes.
Great. Okay, let me just share screen. Okay. And you can see my screen? Great.
Yes, we can.
Yes, good evening. I'm Toby Barring. I work at the Humberton University Hospital in North East London. Shoulder arthroplasty it may feel a bit of an enigma to a lot of you because, you know, compared to knee and hip replacements where you get exposed to them all the way through your training, I suspect some of you may not have even seen a shoulder replacement being done. And that was certainly my experience, and because of that, probably it's not well understood. I think compared to knee and hip replacements, we are probably about 20 years behind them, certainly in the sort of understanding what makes a shoulder arthroplasty last. But also, I think in terms of the sort of postgraduate education. Anyway, hopefully after this you will have a better understanding and feel more confident about dealing with a question about shoulder arthroplasty in the FRCS. Let's see. Hold on, sorry. There we go. So, shoulder arthritis, there are lots of different types. That is the sort of various causes of degeneration of the glenohumeral joint, which may lead on to requiring shoulder arthroplasty. So I don't know if this is going to work because I understand there's a lot of you, but what I want to do is I will start with a little quiz, and I think Imogen is going to let anyone of you who puts their hands up answer this question. We're going to go through a series of x-rays now, all showing different types of degeneration. I want to tell you to tell me what type it is. So anyone keen and want to tell me what's going on with the shoulder?
If you would kindly raise your hand in the participant section, we can then unmute you.
Anyone putting their hand up?
Yes, we have.
A few.
Hi, evening.
Evening.
Fine. Sorry. Yeah, so my name is Ajay, Orthopaedic Registrar. I can see it's an AP radiograph of the right shoulder of the mature skeleton. I can see there is a quite a sclerotic and irregular humeral head, and it's slightly highly migrated as well. The distance between the acromion and humerus also seems to be reduced, though it seems to be it seems to be balanced. I would like to see the other view as well to check the how's the glenoid. The glenoid.
Okay, so the glenoid looks pretty normal, doesn't it?
Yeah.
Okay, so what conditions do you know where just the humeral head is affected?
It's a most likely. I think my first study would be to AVN of the femoral head, which made to only affection of the part.
Very good. AVN of the humeral head.
Yeah.
Very good.
Femoral head. Yeah.
Okay. There's an error on this X-ray. Do you know what it is?
Right.
It's a tricky question. Do you know what a Grashy view is?
Yeah, Grassi. Yeah, I heard that, but I don't know the detail yet. Yeah. So.
Okay, so a Grashy view is an AP of the glenohumeral joint, which is quite different to an AP of the shoulder. And
yeah,
with a Grashy view, you should see clear space between the humeral head and the glenoid, which is not the case. This is more like an AP of the shoulder.
Yeah, it's overlapping.
So this is incorrectly marked as a Grashy view. Anyway, that's just something probably for the MCQs if you're not.
Yeah.
But very good. Well done, AJ.
Thanks.
Done. Okay, let's move on to next one. Inflammatory arthropathy. Okay, probably rheumatoid arthritis. And the key is, as I said, there's a lack of osteophytes. The joint space narrowing is pretty symmetrical. Okay, with primary OA, you're always going to get asymmetrical narrowing of the joint because you're loading in one particular space where the cartilage is damaged more. With inflammatory arthropathy, all the cartilage on the glenoid and the humeral side is essentially affected the same. So you get this symmetrical loss of joint space narrowing. The other feature, which maybe is debatable, is unlike with OA, you get periarticular osteopenia. You get reabsorption of the bone. So rather than sclerosis, you get some reabsorption. Although that's maybe open to a bit of debate. So that's that. But this one would be inflammatory arthropathy. Okay. Okay. On to the next one. What about this one?
I think we've got Nishi to volunteer.
So this is a AP view of the right shoulder, showing reduced joint space between the humeral head and the glenoid with a goatee beard sign. The subacromial space looks reasonably preserved, although there are shadows of loose bodies in there. I cannot comment on the ACJ from this view. So this is in line with the osteoarthritis of the right shoulder.
Very good. Well done, Nishi. Yeah, as you quite rightly say. So the head is still centered on the glenoid, so we assume the cuff is okay. That's very characteristic. I think it's the first time I've heard it as the goat beard sign, but that's very characteristic inferior humeral head osteophyte. And then typically you get more joint narrowing towards the center or posteriorly. You can't appreciate the posterior where unless you really got a CT. But yeah, very nicely described an issue. Well done.
Thank you.
And that's what you often see on these CTs, is that how much posterior wear there is with these. And we'll talk about that in a bit more detail later.
This is the AP radiograph of the left shoulder. They're showing the malunited proximal humerus, and it's united, looks like in a quite vulgus position, and also irregular shape with the reduced joint space. and is migrated proximally as well. So I would label as a second OA due to malunited, and possibly maybe sign of some AVN.
Yes, well, very good. Well done, AJ. Yeah, so this is post-traumatic OA. There is a classification called fracture sequelae, which particularly talks about the position of the GT, because that has a big it's a very determining factor in terms of how you treat these patients if you are going to do an operation on them. And we do see quite a lot of this. And finally, this is I think this is the last one in this series. Anyone want to have a go at this one? I'd say this is quite difficult.
Nisha, you volunteered.
Again, this is an X-ray of the right shoulder AP view with symmetrical loss of joint space, but there is formation of osteophyte inferiorly. There's preservation of the subacromial space. So the features are in some way showing secondary degeneration. I wouldn't be sure what the primary cause is for this, but if asked to choose, I would say still this is osteoarthritis probably.
Very good. The key factor here is that you see this, the glenoid has developed an osteophyte as well. Yeah. And we only really see this with post-instability OA. So if I put these up, this gives you a little bit more of an idea. So these are patients, people have had stabilization surgery, and they all develop these bone formation, sort of beaking of the glenoid. Again, you don't tend to see that so much with primary OA, but that's a tricky one. It's almost like the shoulder's sort of growing its own lateral procedure.
Yeah, shows a proximal migration of the humeral head with a stabilization of the acromion. There's a loss of joint space, and this is most likely cuffed arthropathy, late stage.
Very good. Answered like a true shoulder surgeon. You've clearly been trained very well. I can say that because Nishan used to be my registrar, so well done. Okay, excellent. And we tend to talk about arthropathy rather than arthritis, but by the end of the spectrum of arthropathy, you do very much get arthritic changes with osteophyte formation. So the management of arthritis, we obviously tend to try non-operative treatments first. Shoulder arthritis is often a self-limiting condition in that the patients will start to get pain from their shoulder as it becomes arthritic, and actually change the way they use the shoulder, use it less. And so we see a lot of patients present with sort of mild to moderate osteoarthritis, and it doesn't necessarily progress much beyond there, interestingly. Intra-articular injections work very well. Steroids and hyaluronic acid. We tend to try hyaluronic acid in the younger patients. The evidence is still doesn't show it's much superior to steroids, but the patients like the idea of trying to reconstitute their cartilage. Physiotherapy in primary OA is not particularly helpful, but with cuff deficient shoulders, with this sort of pseudo-paralytic movement you get, it can be incredibly helpful and actually restore a huge amount of function. If you're talking about cuff deficiency or cuff tear arthropathy, that's a whole, and what you do about the rotator cuff in these patients, that's a whole nother talk about superior capsular reconstruction and balloons and patches, those sort of things. We're certainly not going to go into that today. So this is trying to keep this relatively simple, but there is something you can do to the biceps. As I'm sure a lot of you are aware, as you develop primary OA, in majority of patients, you get posterior subluxation of the humeral head. You tend to wear away the posterior glenoid more than the anterior glenoid. And what happens with that is that you find a lot of them have this anterior joint, or what you think is anterior joint line. Actually, you're feeling usually over the bicipital groove, and their biceps becomes quite inflamed. And what happens is the biceps, rather than going over the top of the head towards the glenoid, which would be here, relatively speaking, as it becomes more posteriorly subluxed, the passage of biceps becomes more and more oblique, and it can cut into the subscapularis, creating a cleavage tear, and be quite a source of pain. So certainly in a handful of patients, you can do a biceps tenotomy, and that will maybe buy them another few years before they require a shoulder replacement. And then obviously the options after these sort of less invasive and non-operative treatments is to move on to arthroplasty. So then the question is, which prosthesis? As you can say, that you can see this, I mean, like the knees, like the hips, like the elbows, we've gone through an evolution of different types, and you know, going from the nearest prosthesis in the 70s and 80s, which were non-anatomical, didn't really fit the proximal humerus at all. Then along came the anatomical in the 90s, which seemed to work much better. The reverses, actually, we tried reverses back in the 60s which weren't particularly successful. The sort of the second generation and third generation reverses came in about 20 years ago, and they now seem to be working quite well. And lots of other things have been tried in between. This here came out in France about 10 years ago, and they called it the snooker ball, which is essentially a bipolar pyrocarbon ball. This is here as I call it the Stanmore special. Any of you who've worked at Stanmore may have seen this. Essentially, it's a hip acetabular cup screwed into the acromion and the glenoid. So yeah, so hopefully by the end of this talk, you should understand what the indications for which type of prosthesis are best. Okay. First question, you know, how do you determine whether to do an anatomical replacement or a reverse shoulder replacement? And I think if you stick to these three components, you won't go particularly wrong. For anatomical, you have to have near normal anatomy, intact rotator cuff, and reasonably good glenoid bone. Whereas with a reverse, you can have distorted anatomy, you can have an absent cuff, and you can have considerable glenoid bone loss. And so looking at that, you would think that the indications for anatomical are quite narrow, and they are pretty much limited to primary OA and avascular necrosis. Although with avascular necrosis, we often don't replace the glenoid because the glenoid bone the glenoid bone and cartilage is actually very good quality and tends to tolerate a metal or pyrocarbon head or ceramic head reasonably well. Whereas a reverse is far more versatile, and actually that's illustrated in the NJR now. We're doing considerably more reverses than anatomicals, probably over 100% more. The indications for reverses are now expanding relatively quickly. I don't know, you know, I've been giving this talk for a few years now, and when I first wrote it, it seemed to be quite relevant. The argument between a hemi-arthroplasty versus a total shoulder. I'm not quite sure what's being taught in other parts of the country now, but generally we're moving more towards a total shoulder replacement. You can certainly quote the Cochrane Review, which was published in 2011. But just be aware, it wasn't based on a huge amount. There are only 2 high quality RCTs comparing hemiarthroplasty and total shoulder replacement, and that's, you know, so there's not a huge number of patients to demonstrate the difference. Certainly the difference between the two when it comes to revision is quite considerable, and if you've put in a glenoid component and you have to revise it, you end up with a sort of hollow glenoid, which you'll have to fill with bone graft. Glenoids tend to erode away the whole, hemiarthries tend to wear away the whole of the glenoid, and you end up with peripheral defects and often completely sort of destroy the glenoid. And so that, in a way, almost the hemi can be trickier to revise if that is required. Pre-op assessment of shoulders prior to arthroplasty is very important. Clinical examination, we'll go into this in a bit more detail, is looking at the function of the cuff with emphasis on external rotators and subscapularis. Deltoid function is certainly, if the patient's had previous surgery and for example, something like they've had a proximal humeral fracture and they've had a previous deltopectoral approach or even a deltoid split, we often find that the anterior axillary nerve has been injured and they've lost quite a lot of a deltoid bulk anteriorly. Actually, although deltoid's key for a good deltoid is key for a good shoulder function, there's quite a lot of evidence to suggest that you can still function pretty well even if the anterior deltoid is deficient, but it certainly should be noted. CT and MRI scan. CT is very important for looking at bone stock on the glenoid side, especially assessing how much posterior glenoid wear there is. In primary OA, we do expect the rotator cuff to be essentially intact. It's quite unusual to have a cuff tear with primary OA, and sometimes there are small defects, but not so-called cuff deficiency. But because the implications of having a damaged cuff when you're trying to do anatomical have, if you do go in and find actually they've got a massive cuff tear, that's a real problem if you haven't planned to do a reverse as a backup. And so we do tend to often do MRI scans for anatomical shoulder replacement just to reassure us that there are going to be no surprises. And then of course we always got to keep infection in the back of our mind, especially if it's revision surgery. I think I'm talking particularly about reverses if you have had someone who's got rotator cuff disease and they may have had 2 or 3 arthroscopic procedures prior to it, repairs of tendons, re-repairs of tendons. And so, and obviously we hate infection in arthroplasty wherever it's done in the body. So just always keep that in the back of your mind that you may be dealing with potentially a contaminated joint. And I think that goes with steroid injections. I always make sure there's 6 months between the last steroid injection and me doing a joint replacement on a patient, because it does, that is one of the risk factors for arthroplasty infection. Technique, generally these days, I would say the majority of shoulder replacements are done through a deltopectoral approach. It tends to give you very good access to the glenoid. And you can release the subscapularis very carefully through it. A deltopectoral approach, if you're doing anatomical, you need to preserve the subscapularis. Deltoid splitting has been advocated previously, especially for fractures, because it gives you good access to the posterior aspect of the joint, so you can sort of pick up and manage the greater tuberosity, which tends to migrate posterior superiorly because of the pull of the calf. You can't do it for anatomical shoulder replacement, really, and you do run the risk of damaging the axillary nerve and taking out the anterior deltoid. If anyone has seen a shoulder replacement, you'll be aware of how challenging it can be to get adequate exposure of the glenoid. And I suppose is just a technical point, is you have to position the head and the retractors in a very specific way to allow you to get down onto the glenoid, which may be retroverted already. So if you can't get sort of perpendicular to the glenoid, you're going to find it very difficult to prepare it for your prosthesis. You may have heard about these more modern options. We now have what we call platform prosthesis. So that these are prostheses that are basically interchangeable between a anatomical and a reverse. And the terminology inlay and onlay is relevant to that. So platforms tend to be onlay in the sort of the metaphyseal component sits above the shoulder, or above the metaphysis actually, whereas this is one of the more original reverses, and this is an inlay where the metaphyseal component is actually sitting within the metaphysis rather than above it. And the difference to that really is the biomechanics of the shoulder get changed. You have far more lateralization and inferiorization with the onlays. I'm not going to go into that in detail. That's really quite a complicated component of the reverses, and I don't think you certainly don't need to know about that for FRCS. But I think if you're just aware of these terminologies, that would be helpful. For a anatomical replacement, the subscapularis repair is absolutely key. If your subscapularis repair fails, then your anatomical shoulder replacement is probably going to last about 50% shorter time. And I'll go into that again in a minute. I tend to use transosseous sutures. There's lots of different ways of taking off subscap and repairing it. Some people do a less tuberosity osteotomy. But as I say, the key thing is to make sure you do a solid repair at the end. Lepiscopo now, again, this is moving more into slightly more advanced knowledge, and this is very relevant to reverses. Obviously, in the shoulder, you have essentially 4 internal rotators. You've got your subscapularis, your teres major, your pec major, and your latissimus dorsi. But you've only got 2 external rotators, which are teres minor and infraspinatus. And then with cuff arthropathy, obviously, you can potentially lose certainly one, if not both, external rotators, and you end up with what's called an external rotation lag. And although the reverse will address the loss of elevation, I don't know if you can see this on the video. If you don't address the external rotators, when they lift their arm up, their whole elbow and forearm falls forward, and that doesn't necessarily return function in terms of getting your hand to your mouth and hand to your head. So you've just got. We have now started doing these Lepiscopo. Actually, Lepiscopo was an Italian. He originally described this for obstetric palsy, but it works perfectly well in LOC combined with the reverse. And you basically take off latissimus dorsi and teres major from the bicipital groove and wrap it around the other side of the humerus, so it comes around rather than coming through the armpit and into the front of the shoulder. You basically wrap it around the back of the humeral head and it turns it into external rotator. So as part of your preoperative assessment prior to doing a reverse in someone with cuff tear, you must assess their external rotators and see how much external rotation they have. They often will have a lot of weakness, but they should be able to externally rotate actively. If they don't, then you may well want to consider doing this transfer. Moves on to slightly more depressing part of the talk. Why do shoulder replacements fail? Well, like any prosthesis, they can become infected. The rate of infection has been shown to be higher with reverses. That is probably because when you put in reverse, you lower the humeral head, you then create a dead space above the humeral head, which will obviously it will fill with hematoma, and that's probably a nidus for infection. But actually, as we move along and get better at these, actually the rates of infection are coming down. Dislocation, if that's an anatomical, it's usually because the cuff has failed. It does happen, and you know, certainly in the older patients with the sort of more frail soft tissue, that is a possibility. In reverses, obviously, there's much less cuff, and again, dislocation in reverses is become slightly more historical problem now. We've started lateralizing the glenosphere and the humeral stems. The biomechanics are much more favorable to it being a very stable prosthesis. As I say, cuff failure can lead to not necessarily dislocation, but failure of the prosthesis. It becomes loose, and you get this rocking horse effect, where if you have a functioning cuff, then obviously the humeral component will be centered on the glenoid component, so you won't, the loading will be very central. As soon as you have a cuff deficiency, you'll start loading the edge of the prosthesis, and it becomes loose, and that's known as the rocking horse effect. And then, you know, again, like other prostheses, you can have fracture leading to failure. So there's the million-dollar question: how does a reverse shoulder replacement work?
So the reverse shoulder arthroplasty works by inferiorizing and lateralizing the center of motion of the joint and making deltoid more competent in terms of lengthening the fibers so that they can exert greater force to elevate the arm. Okay.
And how does that bypass the issue of not having a rotator cuff?
So the rotator cuff, basically, apart from centering the humeral head on the glenoid, initiates the abduction or elevation of the arm, and the glenoid being glenoid fibers being lengthened, then can perform this function in place of the rotator cuff.
Okay. Well, you're saying all the right things, but it doesn't really answer the question about why a reverse works and replaces the function of the rotator cuff. It's all about providing a fulcrum, a stable fulcrum. So that is what the primary role of the rotator cuff is, to create a fulcrum for the moment arm, which is the arm, to rotate around. Rather than when your cuff is deficient, if your deltoid contracts, you haven't got the fixed fulcrum, so the humeral head just migrates superiorly, and that is the key to reverse, is that it's not really about changing the position of the center of rotation. It's about creating a stable fulcrum. It is a semi-constrained prosthesis, whereas a anatomical shoulder replacement is a completely unconstrained prosthesis. If you put the two components of anatomical shoulder replacement together and put any sort of shear force across them, they will come apart. With a reverse, they can it will remain stable with really quite a lot of shear force going across it. So if we go on to this slide, we're back to the Stanmore special here. That also works because it is a semi-constrained device. It's got, the cup is captive, and it stops the head from dislocating or moving off its center of rotation. So when you get asked how does it reverse work, you can talk about it inferiorizes and lateralizes the center of rotation, and it optimizes, it stretches out the deltoid, etc. But you also should say it is a semi-constrained device. It's intrinsically stable. It provides fixed fulcrum in the absence of functional rotator cuff. I've put here a medialized center of rotation. Now, that was the original idea that Graham, when he introduced it in the sort of second generation reverses in the 90s. That was the idea of stopping, because prior to that, the glenoid component always got stable, had got loose and unstable. But we've now found ways of lateralizing it. We'll go on to that in a minute. And you're by medializing it, the idea was you would recruit more deltoid into abduction, but actually we now think the external rotation and internal rotation, which the anterior and posterior deltoid help with, are equally helpful. I've just seen the time. I'm going to keep going quite quickly. As I say, that the reverse Niers came up with the concept of the reverse in 1960. But because of having the center of rotation outside the glenoid, outside the bone stock, there were great shear forces pulling it through it, and the glenoid component became loose. And these were completely constrained devices. They had a completely captive cup. You couldn't actually disarticulate them. And he went through various different types in the 1970s. Then Grammel came along in 1985 and talked about the medializing center of rotation in towards the interface between the glenosphere and the glenoid, and that made the glenoid much more stable, or much less likely to loosen, I should say. So now we know we're very confident with the functional outcomes from reverses. Obviously, the main indication is cuff tear arthropathy. Even if you don't have arthropathy or arthritis, if you've got a patient with a pseudo-paralytic arm, they just cannot retrain their deltoid to work over a shorter excursion. You sometimes do have to do a reverse in the absence of significant arthritis. The glenoid is very amenable to sticking structural bone graft behind it to correct glenoid deficiency. So these patients here, primary OA with massive retroversion, loads of, it's very difficult to put an anatomical shoulder replacement. You can do it, and there's now all special augmented options, but it's very difficult to, it can be very difficult to do anatomical shoulder replacement in these, and actually it looks like a reverses are probably the better and more predictable outcome. Tumors around the shoulder, when you have to do large excisions of bone and tissue, again, you're going to be often removing all the rotator cuff, and so some sort of constrained device is will restore more function than trying to put a hemiarthroplasty or a sort of anatomical. And then, as I think I said earlier, that in the elderly with arthritis, when you're worried about the quality of their rotator cuff, even though it may seem intact, it may be an option to do a reverse rather than anatomical. So you do a good anatomical is going to be better than a good reverse in terms of restoring range of movement, especially on an internal rotation, which you tend to lose with a reverse. And this is a picture of someone with pseudoparalysis where they're trying to elevate their arm and all they can do is really shrug their shoulder up because they can't activate their deltoid any more than that. Problems with reverses, just going to quickly go through the complication profile of reverses. As I said, infection, probably because of the dead space superiorly. Dislocation, the Grammon reverse, which did medialize the center of rotation, tended to stick the humerus right underneath the acromion. You then have a vector pull of deltoid, which is more lateral and more likely to dislocate it by pulling it out and up. We've started to lateralize the glenosphere with sort of augments and bone graft. That seems to be less of a problem. Loosening of the glenoid, you've got to make sure that you don't put the glenoid pointing upwards, and certainly with rotator cuff arthropathy, you can have a lot of superior glenoid wear, and so if you don't appreciate that at surgery, then you end up pointing the glenoid up, and then you have these shear forces, and it can just push the humeral component, can actually push the glenoid out of position. Disassembly, this is more of a sort of interesting X-ray rather than key core knowledge, but because of the rotation constantly going on in the shoulder, you can unscrew prosthesis, and certainly a good humeral bone stock is very important to sort of prevent this problem occurring. And then probably, I think this is one of the most relevant problems associated with the reverse shoulder replacements now, are these acromial stress fractures, which shown to happen in about 5% of people after a reverse. And just because you're putting on deltoid so hard, it usually happens between 6 months and 18 months after surgery, the acromion fails, and that's a real problem. And it's very unusual actually for a patient to regain good function after that, because you've detensioned the anterior deltoid. For some reason, and we don't really know, even though they tend to heal, the patient loses a lot of function and will often have persistent pain. And certainly the more recent work has shown that this is probably elderly with a low BMI puts you in a high risk category for a stress fracture. So, those little old ladies where you might consider a reverse because you're worried about their rotator cuff, actually you probably want to rethink that, because probably you may want to be better sticking with an anatomical to try and avoid this particular issue. So sorry, you slightly speeded up there at the end, but in sort of summary, exam pointers, definitely know the difference between primary OA and cuff to arthropathy. For anatomical shoulder replacements, you've got to think you've got to have near normal anatomy, appreciate the posterior glenoid erosion. That's done with a CT scan. You want to demonstrate to your examiners that you understand that the rotator cuff has to be intact. And sometimes it's very difficult to examine patients with primary OA because their shoulder's so sore. So that's probably one of the rationales for getting an MRI scan. For reverse shoulder replacements, the indications are broadening. It's being used much more now than anatomicals. Just make sure you have a good spiel in terms of describing the biomechanics when asked how a reverse works, having the center of rotation in the bone to prevent destabilization and loosening of the glenosphere. Is a semi-constrained device providing a fulcrum, and it has innate stability. And also, as we've just been through, be aware of the complications, both generic complication like infection, but complications that are specific to the prosthesis. So the first question, I think probably some of you were thrown by the wording, but the majority of you got this right. So you can't do anatomical shoulder replacement on someone with a subscapularis tear, a supraspinatus tear, recurrent infection, or cuff deficiency. But you can address retroversion. So glenoid retroversion in primary OA is a very common phenomenon. I would say the majority of people with primary OA have a degree of posterior glenoid bone loss, and that leads to increased retroversion. I mean, the glenoid we know is 8 degrees retroverted anyway, normally, but that tends to worsen with primary OA. It needs to be appreciated, but as I say, we have now the ability to augment the glenoid implants to correct that retroversion. Anything up to about sometimes 20 degrees. At some point, you have so little bone stock because there's so much retroversion that you probably have to bow and do some other prosthesis like a reverse. But yeah, so well done for that. Next question, again, I've sort of asked this in a sort of a double negative way, but which of these mechanisms is not a failure for a total shoulder replacement? And you quite rightly written, the majority of you have answered windscreen wiper effect. That's actually something to do with the biceps, which we see in cuff disease. But yes, the rocking horse effect is the failure of the rotator cuff, edge loading the glenoid component. Disassembly, the prosthesis can come apart inside the shoulder. Infection, obviously, and loosening is other causes. Finally, the Lepiscopo transfer, again, the majority of you got this right. It is a lat dorsi and teres major transfer. Okay. Great. So that's the end of the polling. Close that down. I've got some cases to go through, and anyone who wants to have go at practice vivering, I'm very happy to take them through. It will certainly 2 of them will be based entirely on my talk. So if you've been listening to the talk, you shouldn't have a problem with it at all.
Mr.
We've got some questions from our participants.
Okay, let's do the questions.
I will ask them to you. I received them through the chat. So one of the audience is asking if we just left the subscap not repaired at the end, would that give us enough external rotation rather than doing the laparoscopic procedure?
Oh, that's very good. So this is in reference to reverses rather than anatomical.
Yes, reverses.
No, that's a really good question. Yeah, so that there has been, certainly when I was on fellowship about, well, it's now 8 years ago, we did try very hard to repair subscapularis at the end of the reverse, because we thought it actually helped reduce the rate of dislocation. But that's quite right. You're basically fighting against the external rotators. So there's now actually a move not to repair the subscapularis at all. And I now have not repaired a subscapularis with a reverse for the last, I think, 3 years. I have had no issue with instability. And you're going to maximize the function of the external rotators, which is the problem with the reverse, or the problem with the clinical outcome after the reverse.
Okay, and for Mitwali asking how to reduce dislocation of reverse shoulder arthroplasty.
Yeah, well, I think I was sort of talking about that is that if you've got your acromion here and you've got your reversing underneath there, the Graham style was to medialize the humeral head and the center of rotation as much as possible to try and get the center of the rotation into the bone. But as you go more and more underneath the acromion, the deltoid is going to be pulling more and more laterally, and that's why we think the reverses sort of 20 years ago, 15 years ago, were dislocated quite commonly. Now what we're doing is building out on trying to still keep the center of rotation within the bone, but we build out of a combination of graft and augments underneath the glenoid base plate, and also using onlay prosthesis on the humeral side, which tends to lateralize. So the humerus components and the humerus are tending to now sit slightly lateral to the acromion. So the pull of the deltoid is more medial, and that obviously increases the joint reaction forces and the stability of the prosthesis.
And how to reduce notching in the by the position of the glenoid component in the reverse shoulder?
Again, by the other thing that's happened is that you inferiorize the glenosphere now, and by building it out, you tend to reduce the chance of the humeral component impinging on the scapula and causing notching. It still does happen. We're not too concerned about scapular notching. It doesn't seem to be a there have been some studies that indicate that the more scapular notching you get, the poorer function the reverse has, but it doesn't seem to be a cause to failure. So we're not too concerned by notching.
Brilliant. And last question for now, is there any specific parameters you look on the X-ray to make a critique of reverse shoulder X-ray?
Yes, I think that's a very good question. So I suppose you're looking at imaging of a reverse is quite difficult to get good imaging, because you're only really going to get the scapula in 2D CT, you get a lot of artifact, but essentially you want to make sure all the screws are in the scapula, the extrusion of screw ends. The glenoid ideally should be inferior, and it should be tilting down. And obviously, if you've got bone graft underneath the glenoid base plate, then you want to make sure that that bone graft has incorporated and it hasn't been reabsorbed. I mean that's one of the great things about these base plate structural grafts, is they tend to heal so well. And if now with reverses, when it comes to revising them, it's very rarely the glenoid is a problem. It's usually the humeral components become loose. Yeah, I suppose you want to you want to make sure that the humeral component is well seated, and that there is good fixation within the metaphyseal bone. One thing, I actually just sort of going back to the previous question about inferiorizing the glenosphere. The inferiorization and lateralization is very good. The only problem with that is we are seeing more brachial plexopathies, because you're really stretching out the arm, and in some patients they are getting nerve injuries, which do usually recover from fully, but it can take quite a long time, and it's pretty uncomfortable for them. So it's just something you need to consider.
Yeah, thank you very much. That's all the questions for now, and we have 2/3 participants for the Viva.
Great. Excellent.
Yeah. So
are we okay for time? I know.
Yes, no, we're fine for time. Just to reiterate for the people taking part in the Viva, this will be recorded, but more for educational purposes. So please, if you've got any, I know we don't normally record some of our Viva sessions, but just to remind people, this will be recorded. Okay, but
don't worry, I'll be very kind. Just take me through the pertinent features on this X-ray. It's an AP of a shoulder. I'll give you that. What else can you see that's going on here?
So it looks like a quite severe rotator cuff arthritic shoulder with the proximal migration, acetabulation of the acromion, and there is a bone on the glenoid, and it's quite proximally migrated. Also, it's quite inferior osteophyte and some cystic changes in the humeral head. And yeah, glenoid is not looking too bad in terms of a wear or osteophyte there. So
okay, like, so tell me how you would assess this patient if they came into your consultation room.
So I'll ask the history. What is the presenting complaint, and since how long, and how they are affecting their day-to-day activities, and any right-handedness as well, like right or left, and what are their routine activities, whether they do any job, and also do they do any recreational or hobbies, and are there any medication and past medical history in terms of if you like to plan for surgery, then pre-anesthetic review as well. And I would like to get an other view as well. And in my pre-op clinic, I'll request for a CT scan as well to assess for the bone stock on both sides.
Okay, very good. Just going back to their history, is there anything in terms of their sort of day-to-day function, is there anything particularly you would ask of them about? This is they say this is a 75-year-old woman.
Yeah. So I'll ask if they were day-to-day activities, like how much overhead activities and other activities they able to do or not able to do, and what are their expectations out of this consultation today.
Yeah, okay. And what might you see on examining this patient?
So I would like to examine by starting the inspection, looking from the front, side and back, looking the rotator cuff muscles. I presume it's proximally migrated. It seems to be prolonged or chronic condition. They will be well atrophied. I would like to check the function of the deltoid, which will determine. Also, I'd like to check the function of other muscles like trapezius and latissimus dorsi, in case want to go ahead for surgery, and check the formal assessment of the function of the rotator cuff as well, and like to check the movement in terms of how much flexion, extension, rotation, and abduction.
What component of the the rotator cuff would you be particularly interested in?
It's the external rotation and external rotation, I would say. Yeah.
And how do you assess external rotation?
So it's mainly infraspinatus and teres minor. So there are two ways. One is putting the arm by the side and asking them to rotate against the force. One
yes.
is the Hornblower sign.
Okay.
Abduction and then external rotation of the shoulder.
And how do those, between those two, take it Hornblower sign, which rotator cuff muscle are you particularly assessing with the Hornblowers?
For Hornblowers is the infraspinatus. Sorry, teres minor for the Hornblower sign, and the infraspinatus is for external rotation in by the side of the arm, then asking for external rotation.
Okay, very, very good. What are you going to offer her? Okay, so 75-year-old woman, she's got some shoulder pain, actually functions quite reasonably well preserved. What treatment are you going to offer her?
So I'll ask what treatment she had until now, whether she had tried any physiotherapy, any injections, steroid or hyaluronic acid, and what effect she got with that. And if it is not much effect, then most likely she's heading to have a reverse shoulder replacement, because on X-ray seems to be quite high reading. So I'm suspecting there will not be any rotator cuff to support for the anatomical shoulder replacement. Okay.
That would be in 5 minutes.
That would be 5 minutes. Okay. All right. Well, let's, because it's getting a bit late. I'll stop you there. AJ, I think you did that really well. So when you're, I think when you're shown an X-ray like this and asked to explain what sort of history you take, you've got to, the sort of three components really to the history taking is you've got to elicit their symptoms and how much pain they're in. You've got to work out how much dysfunction they have, and that, you know, that's very important to ask things like hand dominance. Who's at home with them? Are they by themselves? Have they got a partner or children who help them get by? And then the third component is you're sort of, when you see an X-ray like this, you're sort of thinking, okay, I think this patient might need a shoulder replacement. And then, so then your third point is, are they a suitable candidate for surgery? Are they fit? Are they compos mentis? Do they have good cognition and they can sort of understand the sort of implications of surgery and deal with the recovery period? So just make that very, in terms of history taking, and this applies for, you know, whether you're doing a shoulder replacement, a knee replacement or a hip replacement, you know, just make it very clear that that's what you're trying to elicit from the history. The other thing I think with this is that, you know, clearly this has been going on for a very long time, and always sort of make the point of asking whether they've had previous surgery, because they may have had a failed cuff repair previously. You know, that then makes you start thinking, okay, is this potentially an infected joint? You know, I would need to consider that prior to doing something like prosthesis. I think, again, you know, your examination was very good. A patient like this will, interesting, actually, will probably have quite good function. They have created a perfect acetabulum from the underside of their cranium. This is what we call a shoulder hip or a ship joint. You wouldn't, if you became pseudoparalytic as soon as you had migrated your head superiorly, it's unlikely you would have been able to do this to the acetabulum. So this patient's clearly retrained their deltoid and has actually probably got reasonably good elevation. And I expect they've presented now because although they've got a reasonable range of movement, they're sore because everything is arthritic and there's nothing. So, you know, just say that, you know, it may be that the patient has pseudoparalytic range of movement, or they've maintained good function. This varies hugely between people, and it often varies depending on how good a physiotherapist they've seen as well. The other thing to mention on observation is look at their biceps. They may well, she may well have ruptured her biceps, so she may have a Popeye sign, as well as the wasted rotator cuff musculature. And yeah, and make a rough fuss about, you know, how you would examine external rotation. You quite rightly said it's unlikely that maybe they can't get into a position to do a hornblowers, but you know, I would put their elbows into the side, externally rotate their hands manually, and ask them to hold it there. And often what happens, I'll show you on my video, is that they have reasonable passive range of movement, but as soon as you let go of the hand, their hand just flops around across their tummy. That tells you that they've got really no external rotators. Very good, well done. This is a 65-year-old retired accountant, or let's say a retired lawyer, and he has had primary OA of his shoulder joint for the last 5 years, which has been managed reasonably successfully with steroid injections. But he is now struggling, and the steroid injections don't seem to work. Can you just tell me how you would counsel him for having a shoulder replacement? Go through the consent process. Take us through the consent process for anatomical, for a shoulder replacement.
Okay. I will explain to the patient that there are different treatment options, which are injections, physiotherapy, and probably that all conservative treatment has failed now. So the other option is the surgery, in which we replace the joint, and I will show him the probably a picture as well, or X-ray as well. And it will be, we will change the head and replace them, head and the side. There are some risks involved as well. The one is first is the infection. There will be a scar. His pain will improve, but I can't guarantee that how much range of movement he will get for that. And then there is a risk of nerve injuries, because we will be operating very near to the neurovascular bundle. The other thing is that
which nerve is most likely to be injured?
It's the axillary nerve.
Axillary, did you say?
Axillary nerve.
Yeah. Okay. Yeah.
Axillary nerve, and also that this may get later. This may get loose as well, and he may need another surgery as well.
Okay. Any other complications you can think of?
It can also dislocate as well.
Anything else? No. Okay. Fine. And okay, so you're now in theatre with the patient on the table. He's asleep and prepped, ready to go. Just what approach would you use for anatomical shoulder replacement, and just tell me how you would do the approach?
I will use the delta pectoral approach. The patient will be in a slightly proper position. My landmark will be with the coracoid process, and I will go laterally to the deltoid tuberosity. After taking the skin subcutaneous tissue, I will look for the fat to see the cephalic vein. I will lateralize, mobilize it laterally towards the deltoid. I may have to ligate some tributaries, and I will make my way with the finger between the deltoid and pectoralis major, and then I will dissect the deltopectoral fascia and then subscapularis. I have to I would like to preserve the subscapularis, so I will take the lesser tuberosity with the subscapularis and expose the head
what would be the landmarks for telling you where the subscapularis is? Because you go in, there's a lot of inflammatory tissue around. It's all a bit scarred up because of the arthritis.
I will look at the biceps, long head of biceps, because it will be between the lesser and greater tuberosity, and lesser tuberosity will be anterior.
Okay, anything inferiorly, which tells you the inferior border of the subscapularis?
That's the pectoralis, inferior border of subscapularis. Yeah, I will just go to the pectoralis major insertion.
Okay, all right, fine. Okay, and that's fine. All right. Well, I think we'll probably stop there with that one. That was good.
That's 5 minutes, right? Yeah.
Is that 5 minutes? Okay, perfect. That was good, Mohammed. I think the key with if you get asked consent form is to go through the consent process, you've got to keep a couple of things in mind. You've got to keep the idea of shared decision making. Okay, and I can't remember what it's called now. The Montgomery ruling. There it goes. So you've got to make sure that the patient is fully aware of that. A shoulder replacement is not going to save their life, but it will change their life. So you must always consent them in a way that they feel like they are being empowered to. They're given all the information about the operation and the outcome, the recovery, that sort of thing, and they are then able to go ahead and make a decision based on that information. So, you got all the right complications, maybe could be a bit more fluent, but you need to say, okay, so we're going to do a shoulder replacement. We can do a shoulder replacement on you. If we don't have a shoulder replacement, you're probably going to continue to get pain and loss of function, which might get worse over a period of time. We can continue to manage that as best we can with a combination of oral analgesia, injections, and possibly physiotherapy. But with a shoulder replacement, you will come into the hospital, it will be inpatient care, you will stay in hospital for 2 or 3 days. Afterwards, your arm will be in a sling. It will take you 6 months, it will take you 6 weeks to regain reasonable day-to-day function. Your shoulder will continue to improve for up to a year. 90% of patients who have this operation are very happy with the outcome. The other 10% either have a problem which is amenable. Maybe between 2 and 4% of patients who have this operation are probably no better or slightly worse than they were before the operation. That way, you have demonstrated to the examiner that you you've been through that modern consent process. So and again, these are generic skills. They apply to consenting for any operation. And you don't have to. The examiner's not going to pick you up on not being exact on this timeline, but you just need to go through not just reading out the complications, which is what we used to do, but you need to paint them the whole picture of what the process of coming into hospital, have the operation is in the recovery period. The delta pectoral approach, very good. Yeah, the skin incision centered on the coracoid. You quite rightly identified the cephalic vein and retracted it laterally. After that, it becomes, you can start to tell who's done this procedure more recently and who hasn't. But just have a look at it maybe in Hoppenfeld or another sort of operative manual. When you go through the superficial muscle layer, deltoid and pec major, talk about identifying the coracoid and the conjoint tendon. You go lateral to the conjoint tendon. You want to get a retractor underneath the conjoint tendon. That actually protects the brachial plexus. Actually, if you retract, if you retract over the conjoint tendon, you tend to stretch out the brachial plexus a bit. You would, you say you can also add components like I will put stay stitches in subscapularis before I release it, so I don't lose it into the under the conjoint tendon. And you, as you said, you use the bicipital groove is the most important landmark when you're doing the approach to the shoulder, because that it's very easy to find because you see pec major inserting just lateral to it. The inferior border of subscapularis, have you heard of the three sisters? So these are three blood vessels that run along the bottom of subscapularis, and they're the circumflex vessels, and they indicate the inferior border of subscapularis. And they usually, you need to tie them off or diathermy them before you divide them, otherwise they bleed a lot. So yeah, I would just have a little bit more. Try, when you ask an operative technique, always try and describe it as though you've done it lots of times in practice. In the heat of the exam situation, it's more difficult, but there's sort of little bits you can add which sort of customize, personalize it. Very good. Well done. Nishu, tell me what you can see on this photo.
So this is a clinical photograph showing patient's left arm, which is showing ecchymosis on the medial aspect of the elbow with a muscle bulge in the superior aspect, probably showing a reverse Popeye sign.
Very good. Okay, so this is a 35-year-old plumber who was trying to stop a heavy object which was falling off the table. What would you like to ask him about in the history?
So the mode of injury, as you said, he was a mechanism. Sorry, say again, he was what his hand dominance is, and I then would explain to him that the most and then examine him and confirm the diagnosis of a distal biceps tendon rupture by performing the hook test.
Okay, all right. What are you going to, how are you going to counsel him for the treatment going forward?
So I'd explain to him that the options going forward are to do nothing and do some physiotherapy and let it heal by itself, or their option is to treat it by an operation. The conservative treatment is likely to lead to loss of about 30% of the bicep strength, maybe more. Whereas in the operative option, can
you expand a bit on loss of bicep function? What do you mean by that?
So the main functions of the biceps is it is a strong supinator of the forearm, inflection of the forearm, and so that's the main function lost. So the flexion strength is lost to lesser extent, but the supination strength is largely lost. If we treat it conservatively, because the tendon will not heal in the anatomical position, whereas the function is more likely to recover with an operation where we attach the tendon through a drill hole in the radius at the bicipital tuberosity. The risks of the operation are again like any other operation: infection, mainly largely, but there's lots of nerves that travel around here, and the lateral cutaneous nerve of the forearm.
Excellent. Very good.
Yeah, is at risk here. And I think at least 10% of the patients get that, but it recovers later on.
In my book, it's more. Which other nerve is at risk?
Well, during the dissection, fishing of the tendon, the median nerve is at risk when we are fishing the tendon from the superior part of the incision.
What about, any other one which is more at risk when you're reinserting the tendon into the radius?
Probably anterior interosseous.
Okay. What are the complications from surgery?
So again, there is, like any other tendon repair, there is risk of the repair failing and re-rupture risk. And apart from that, there is risk of there's risk of stiffness or reduction in the loss of function and not able to getting the full strength.
So you say stiffness. What might cause stiffness around the elbow with this sort of operation?
Sometimes if the patients present late and we are beyond 2 weeks, it's difficult to suture the tendon back. So we have to flex the elbow to get the tendon to the bicipital tuberosity, in which case then we keep them in flexion for some weeks and then gradually stretch them out.
Okay. Have you done a distal biceps repair?
I've assisted a few, partly done one, but you know.
How would you repair the tendon back into the bone? How do you reattach the tendon to the bone?
So we use the single incision technique from anteriorly. We supinate the forearm fully and then make a hole, 2 different diameter holes, and then pass the endo button and flip it, which then,
That's 5 minutes.
Brilliant. Yeah, you did that very well, Nishi. Well done. Yeah, I mean, the quite rightly. So I gave you the information about his occupation. You asked straight away about hand dominance. The key, you said biceps function will be reduced. Actually, you don't tend to lose very much flexion strength at all because brachialis compensates, and you've got the other part. You want to just head straight for the loss of supination. You lose between 50 and 70% of supination strength. And that's the problem with these guys who do manual jobs using screwdriver, that sort of thing. If you lose supination strength, that can be very disabling. Quite right on good on the complications. The nerve that can get injured is posterior interosseous nerve. As you pass the endo button, you have to pass a passing pin through the hole in the radius and out through the dorsum of the forearm, and you can catch the posterior interosseous nerve that way.
Okay, sorry, I didn't know that.
And the complication actually more with the old-fashioned 2-incision Boyd Anderson technique was the formation of HO. Just keep that in mind as part of your but you know, you would have scored pretty high with that. I think you did that very fluently. Well done.
Thank you.
Very good.
Okay.
Well, I think I'm out of questions now. Over to you guys.
Brilliant. No, that's fantastic. Thank you very much, Mr. Barring. So I think it's 9 o'clock now. So I know a lot of people are coming out of the fast. So if people need to go and eat, it's probably time to bring this to a close. I'm really grateful for a fantastic talk tonight. Upper limb it does come up quite a lot in the exam. So, and obviously this talk is going to be on our website, the FRCS Mentor YouTube channel, and the OR UK. So please refresh yourself with it beforehand. Again, with approaches, there's lots of delta practical approaches. A really important approach, a very favoured one with examiners, particularly in the Viva and the basic science, because it can go one of 2 ways. It could either ask you how to approach a proximal humeral fracture or doing an anatomical shoulder. So there are subtle ways to know who's done it and who hasn't done it. And there's certainly videos out. If you haven't seen it, I appreciate sometimes it's difficult to go and see it if you haven't had a chance to do an upper limb job. There are fantastic talks on YouTube of how to do all sorts of different approaches. So I know reading Hoppenfeld is one way of doing it, but if you have a very visual brain, it's always good to have a look and see how someone's done it online. And I know Mr. Van Rensburg, who's talked for us before, has got a fantastic video on YouTube for it. So I highly recommend having a look at those. Again, I say thank you very much for everyone coming today. I appreciate for a lot of people the results day as well. So fingers crossed people had a good, were successful. Otherwise, we're here to support you and get you through this. So don't worry. Okay. So without further ado, we'll also say goodbye and wish everyone a good night. All right. Okay.
Bye. Good luck, everyone.